Sean has his own lived experience of suicide, but has been working in this space for many years. Ireland comes with their own particular group of problems around suicide, and I'm certain Sean will talk about that. And when I was chatting to him, he said, I'm not an academic, I work practically on the ground, and he's done some amazing work targeting sports coaches and people like that, and has a great story. So even though our welcome to our international guest has been very warm, I'd really hope to a fellow Irishman we'll give him a really special go. So let's welcome Sean to the...
Good afternoon. I'm glad you all got an opportunity to stand up and stretch your legs after 4 hours almost of sitting in one place. John, thanks very much for such a wonderful introduction. I'd like to thank both yourself and Jorgen for the opportunity to come here to Australia and speak to you. As John said, I don't come from an academic or a research background. My own professional background is as a psychiatric nurse. But I'm involved since 1996. I'm working on a full-time basis in the whole area of suicide prevention in a region in the southeast of Ireland. It has been a long journey to get here, 28 hours. But just as I was about to come in, well, initially landing in Auckland, I kind of reflected back on what my mother told me about when I was leaving Ireland to come here. She said, Sean, she says, remember, you'll be there much faster than your ancestors. And they didn't come on the convict boats. But my grandfather's brother left Ireland when he was 17 years of age, because my grandfather was the oldest, so he got the land and he had to stay farming. His younger brother left at 17 years of age, and he lived just outside of some part of Sydney. I don't know the address because we lost contact after our grandfather died. He lived to be 96 years of age. And every 2 months, those two brothers communicated with each other for 80 years. So what a connection that was. And if we talk about communication and keeping up communications, just think of the difficulties there was in doing that over that extended period of time. I get frustrated when I don't get an email back from my wife after 5 or 10 minutes when I'm here. So that was a great challenge. As I said, I've been working in this area since 1996. And basically, I went into it to get something to add to my curriculum vitae. I don't make any bones about it. That was the background. But that all changed very dramatically in 2000. On the 1st of January in 2000, when my first cousin, who's also called Sean, we were a mirror of each other. He was a psychiatric nurse as well. Took his life by suicide. So from something that was a career pathway to add something to my CV, all of a sudden became something very passionate to me. So that's a lot of the area where I come from is very much because of the personal experience of having been bereaved by suicide, and the experience of my family and extended family to being exposed to that. This is a photograph of the beautiful River Slaney that flows through the town that I'm from in the southeast of Ireland called McCarthy. Just at the end of the river, as you're looking downstream, as we would call it, on the right-hand side was the Christian Brothers School where I went to school. On the left-hand side was a big Victorian psychiatric hospital that housed 850 people for a county that had a population at that time of probably about 110,000. Had a huge impact on all of our perception of mental health services and the whole area of the stigma that came around with it, because it was a walled-off institution that nobody could either get into or get out of. And of course, when I daydreamed about playing sport at an elite level, looking out the window on the school across from it, the teachers would say, "McCarthy, you will end up in the mental hospital." Little did I know that I did. So as you can see, it's a beautiful river. It's where I spent my youth fishing, rowing, partying, courting, and a lot of the things that my mother and father wished I hadn't been doing. But as you can see, that's what the river looks like. That's it from a different perspective. Because in 2002, in a period of 7 days, 5 people went off that bridge across the Slaney River and died by suicide. At that same period of time, there was actually 7 people died by suicide in an 11-day period. in a town, and it's in environs that has a population of about 20,000. 2 of the 5 people who went into the river were friends of mine. One that I played sport with at an elite level, and one that I went to college with. Their bodies weren't brought back from the river for a period of 6 weeks. So there was the huge impact that had on the town and on the community was very, very strong. And coming from the town, I learnt an awful lot in relation to that. The presentation that I'm going to do today for the rest of it is basically going to touch on 3 particular things, and it seems, and I'm sure, John, this didn't happen by accident, but there was a lot of talk about strategies and national strategies and local strategies, and that's why I'm going to kind of look at what we do in Ireland in relation to a national strategy and how that gets implemented down into the local regions, like into the areas where I am. I'm going to then look at 2 particular programs which are kind of practical implications of what we do. One is about a service that we deliver into primary care, and one is something that I'm very passionate about, is the whole area of sport and the role that sport, and particularly sports coaches and those, can play in relation to suicide and suicide prevention. Okay. Suicide prevention model nationally. In Ireland, we have had for the last 10 years a suicide prevention strategy which was known as Reach Out. And Reach Out was sponsored by the national government. It was a very kind of comprehensive national strategy, but I certainly would say for somebody who had worked in it for the duration of that, an awful lot of the actions and the recommendations were very aspirational. They sounded lovely and they read lovely, but the actual practical implications of them was very, very poor, so it was. So we have come to the end of the national strategy Reach Out. I would have to say that there wasn't the proper investment, there wasn't the proper resources, and there wasn't the proper structures put in place at the very, very beginning of that to allow it to have the effect that it probably should and could have had. We're now in a different space, because when I will return back to Ireland, next month we will be launching our new national framework for suicide prevention, which will be over a 5-year period. And the key thing that is included in the new national framework is, as Dr. Martin had said earlier, outcomes. It's all about outcomes, goals, and how do we measure those goals, and what are the specifics about getting those done. It is primarily going to be about services and the improvement of services. We've heard a lot this morning about training and the need for training. But what we have found in Ireland, because we've been rolling out Assist and Safe Talk and all of those programs through Living Works, through our office, which covers a population of 500,000 for 12 years. We train about 1,500 or 1,600 people per year in Assist and Safe Talk and Suicide Talk, along with some of the other programs that we have. So there is a very, very comprehensive program that has been done there. But we have a national strategy, but what we found initially when we were starting out with our initial strategies was that the whole area of coordination was very, very poor. So what the government and our Department of Health did was that they established a National Office for Suicide Prevention. And the National Office for Suicide Prevention is centralised in Dublin. It has a director of the National Office for Suicide Prevention who has responsibility for the delivery of the recommendations that will be in the new framework. And the service is actually embedded in the mental health division of our health services. So it's a national strategy led by a National Office of Suicide Prevention, embedded in the mental health division of our health services. The national strategy, the current one, has 26 action areas in the strategy. That will be much, much smaller than that in our new national framework, where there's going to be seven specific strategic objectives with actions flowing from each of those. The National Office of Suicide Prevention has a coordination role. It oversees the implementation, the monitoring and evaluation of the strategy, and the key areas that it looks at is the development of the delivery of funding, negotiating at central government level for increased funding for suicide prevention, for training, research, coordination, monitoring and evaluation. And then the whole area of developing partnerships. So if we had something as wonderful as Mason Construction in Ireland, because one of the difficulties we have is doing suicide prevention in the workplace, the National Office for Suicide Prevention will be negotiating with you to provide funding for you to be able to do this as part of our national framework. Ireland is a small country, but we're divided into a different number of community healthcare organisations. So there is one of me in every one of the healthcare organisations. We all have a line management structure regionally within mental health, and we work strategically with the National Office of Suicide Prevention. So our national office sets the national agenda, but locally we have the autonomy to be able to do the implementation work and support voluntary community organisations or anybody else who is interested in the work of suicide prevention. We develop our own initiatives and projects locally based on local need and consultation. I'm just going to talk about two of those particular initiatives. One is the first one, which is what we call the Suicide Crisis Assessment Nursing Service, which has been known as SCAN, and the second one I'm going to talk about is QPR for Sport. So SCAN. When we were doing our local consultations in County Wexford, one of the things that we were constantly hearing from GPs, primary care, was, it is so difficult to get people referred into mental health. Not that there were blockages in the way, but that it just took too long for the person to get in. So somebody in crisis may get an appointment for 7 days' time, or it could be 10 days' time, depending on the geographic area they were living in. Too long, they said, for us. Develop something for us that we can be more responsive to people who are in crisis. So this is the kind of the area where the work that I come in, and that I do is I came back and I said, okay, what could we do? We went out, we spoke to the GPs, we looked for what they wanted. We spoke to people who had been attending services. We wanted to hear from them what their experience was of going through the traditional means of getting into mental health services if it was required, and we constantly got the same thing back. So what we decided to do was we decided to get on a pilot basis with funding from the National Office to provide a speedy response to GPs and primary care teams for when they had somebody who was in suicidal crisis presenting to their GP practice. They wanted somebody to be able to provide a comprehensive clinical assessment of clients presenting with deliberate self-harm or suicidal crisis. So the person could be in suicidal crisis, they didn't have to be presenting with a mental illness as such, so they didn't have to have a diagnosis of mental illness, and it goes back to the point that was being made previously by a previous speaker, Dr. Martin, about the whole area of depression and mental illness. People were presenting with issues of everyday living. And that they wanted, the GPs and the people who were attending services wanted to have a partnership with the GPs where they could institute a health and social care package to meet clients' needs and social care needs. So basic enough, simple enough type of a request. So what we did was we developed the service. We established it in 2008 and in 3 phases: a preparation, a development, and a consolidation phase. And we had it evaluated in 2011 using a mixed method exploratory sequential design was used to conduct the evaluation. And I'm not from a research basis, so if you wish to have a researcher to explain that, please find one later on. Very quickly, some of the conclusions that we got from the evaluation was that the data from all sources confirmed that without SCAN, people in suicidal crisis were more likely to be referred to the accident and emergency department of the local general hospital or to the psychiatric service. As a matter of course, irrespective of what their presenting features were, they were going to get a presentation or a referral to mental health services. Findings also showed it confirmed that the SCAN service provided more timely access to people who were in distress and people who were in crisis, so that they were getting a response. In a lot of times, they were getting a very comprehensive assessment within within a period of 4 to 5 hours. It confirms that the interview data from SCAN facilitated more timely review overall, so there was a much more comprehensive review done of the person presenting within the mental health services, but also with the person who was doing the assessment and the GP. It also said that it confirmed that SCAN is associated with a reduction in hospital admissions and a reduction in deliberate self-harm. In the area where we had done the pilot, it was a standard was that everybody would be referred if they had a mental health difficulty to mental health services. The SCAN service reduced that by 60%. So GPs ended up referring about 40% of the people who were seen and getting a comprehensive assessment to mental health services, which allowed mental health services to concentrate on what they were doing, but also was the other 60% of people. It wasn't that they weren't referred anywhere else, but they were referred to maybe addiction counselling, to relationship counselling. They would be referred to money advice and budgeting services if it were financial issues. So whatever were the presenting features, we have a very, very broad amount of services within the area that they can be referred to. We got better at treatment adherence, reduction in referral to mental health services, and something that we ended up finding that we didn't set out to do, but we got an increased GP's understanding of suicidal behaviour and the management of suicidal clients, simply because of a specific clinical nurse specialist attending to the GP practice to see the client and work with the GP. So it is an assertive outreach service that goes from mental health services out into GPs. Therefore, they get the assessment, the client gets the assessment in the GP's practice and doesn't have to go through the hoops that traditionally had to go by telling their story to the GP, being referred to a central admissions point in the mental health services, telling their story to a junior doctor in training perhaps, telling it to a senior registrar maybe, and eventually telling their ultimate story to a consultant. I'd give up if you have to go through all of those. So this is a much more speedy way of getting into the service. The service was evaluated, and following the evaluation it has been part of the new national framework that this service is going to be rolled out into all of the health areas across the whole of Ireland, which covering 26 counties in Ireland, and I have been given the responsibility for leading out in the rollout of that. So that's just one kind of an example of the type of thing that we do. The other one that I want to talk about is QPR for sport. There are a couple of things, there are three things I'm passionate about: family, my work, and sport. All my life I played sport. I am a sports coach. I'm an administrator in sport. So I firmly believe that there is a huge role in the whole area of sport. And I'm sure that if I ask everybody here to think back to their youth, who are the people who had the greatest influence on you? When I think back, I think of a teacher and I think of a sports coach. I don't think of anybody else, because they were significant people in my life. In 1984, just as I had gotten to probably the peak that I had wished to get to, which was to represent your county, and John would know that, being a Cavan man, my ambition was to represent Wexford. I made my debut in 1984 for Wexford, and during the game I shattered my leg. And just having achieved it, it was taken away from me, and I never played sport again at a competitive level, at that type of a competitive level. And that had a huge impact on me. A massive impact, because having striven all my life to get to something I had achieved, and it was taken away just like that. So that caused me a lot of, I suppose, mental health difficulties. Thankfully, I've never suffered from mental illness, but certainly I struggled with coping with that. And the person who helped me through that was the coach that I had at that time. So that was very significant. The other thing that brought me to here was that a lot of my friends have played sport at an elite level. Most of them at a higher level than I played, and a number of them have represented Ireland. And my father managed the Irish boxing team for very many years, and he was involved in the development of the elite boxing academy in Ireland, which is just winning everything. But when I tried to have a conversation one evening with 6 of my friends, after been playing golf, after going into the bar just to have our first drink, I just mentioned about mental health, and they all said to me, "Oh, will you go away? You're not working now." Right? I said, "Okay, we won't have this conversation." Before we left that pub, every one of the 6 of those had come to me and spoke to me about mental health difficulties that they had in relation to trying to play in sport, but didn't want it shared with the others. So that also taught me something. So I've been working with the QPR Institute, Dr. Paul Quinnett, in trying to develop a QPR for sport. And we're doing it based on evidence that's emerging, and there's not a huge amount of evidence around this whole area, but certainly if anybody is interested in it, David Lester and John Gunn have written a very, very wonderful book called Suicide in Professional and Amateur Athletes, and that's a wonderful resource for anybody who wants to read up about this. And there's an Australian influence, because I've also done some, trawl through all of the papers and what have you, and David Pearce in 2010 did a study where they looked at Australian rural football club leaders as mental health advocates, an investigation of the impact of the coach project, where they trained coaches in mental health first aid. And the key finding in that was that more than 50% of club leaders who undertook the training showed increased capacity to recognise mental illness. 66% reported increased confidence to respond to mental health difficulties in others. And they report that this, sorry for the spelling mistake there, they report that this training built upon their existing skills, fulfilled their perceived social responsibilities and empowered them. And that was a project that was done here in Australia. So, photograph there of the guy with the funny looking stick. And Miff Maple had told me to be very careful when I talk about hurling in Australia, because it also has a different meaning. But in Ireland, hurling is a sport, and this was a game that I played. That guy in the red and black jersey, his name is Wayne Hutchinson, and I'm not sure if he's anywhere connected with Hutchinson Builders, but probably somewhere back the line, they probably are. He, like myself, strived for years and years to play at the top level, and he got to do that. But he wrote a blog just there before Christmas about his battle with mental illness, depression and suicidality. And he says on the day he made his debut that he should never have played that match. Why? In the build-up to the game, I had a really tough time with my depression. Mentally I was drained, and that is the last thing any hurler needs to be before the championship match, let alone your debut at that level, is to feel that way. Now, when he made his debut, he made it in front of 45,000 people. He was substituted and taken off the field after 24 minutes of play because he just wasn't up to the game on that particular day. We now know why, because of his battle with depression. But nobody in the dressing room and nobody that was connected with him and the playing and in the sport was able to recognise that he was battling with depression. There's a major study that was done in Ireland with 8,222 young people between the ages of 17 and 25 years of age. And one of the stark findings in that was that 30% of them owned up to having been seen by a mental health professional at that stage of their life. Another 20% said that they knew that they needed to be seen by a mental health professional, but were afraid to go to it. So 50% of the young people between the ages of 15 and 25 either had a mental health difficulty or knew that they had a mental health difficulty they need help and support from. If you translate that into a sport environment and into a team environment, that's half of your team. So the QPR for sports is a targeted bespoke training. It's very similar to Safe Talk. It's very similar to what they're trying to achieve in Safe Talk and Suicide Talk, the same that Living Works are doing, only it's just taking a slightly different approach perhaps. But what I'm trying to do by developing this is making it very, very relevant to sport, because what I have found over the years is that trying to get sports people to do this type of training when their principal objective is in the development of athletes and in coaching. And when I talk about coaches, I talk about physiotherapists, I talk about strength and conditioning coaches, I talk about all of the people, all of the network that are gathered around sports people, that unless you make it relevant to them and in their environment, they don't want to know about it. I'm a sports coach. My objective as a sports coach is to win. And I have been successful in most of the teams that I have been there with. If I can get anything that will give me an extra 5% to improve the performance of the individual or the team, I will strive my utmost to get that 5%. So I will do hydration, nutrition, strength and conditioning, skills, speed, stamina, all of those things that are required, to develop a good sports person. Now I'm beginning to see, what about the big area that perhaps has been neglected for too long? I'm not talking about sports psychology, which is to prepare the person for the day, but what about their mental health that's impacting on them and the day-to-day life that they're bringing to the field when they're going to be performing? That we need to build up a capacity within sports organisations and a capacity within sports coaches and people who are working with sports people to be able to support them. Similar to what you're doing in mates and construction, but it's taking it to another area. And look, sports is a professional approach now, so it can be looked at like a workplace, be it at an amateur level or be it at a professional level. But certainly we need to adapt this, because this is where our young men, particularly are able to be gotten. Australia, sports mad country, New Zealand, Ireland. It is one of the areas I think that hasn't been addressed and hasn't been tackled as of yet. It uses a basic QPR training. Some of you may be familiar with QPR, which stands for Question, Persuade and Refer. It was developed by Dr. Paul Quinnett in Spokane in Washington. And there's many people have been exposed to it in Australia, New Zealand and Ireland. But the difference, I think, in the QPR sports approach is that what I firmly believe and what our thinking coming as we work with the QPR Institute is that for it to be really successful, it needs people who have a knowledge of sport, who have been there, who have played, who have coached, who know what it's like to be in a dressing room, who know what the pressures are that are being placed on athletes and people to perform, and the impact that can have on them, even in their day-to-day living. So I think that's a crucial part of it. The training, I always believed was good, but there was something lacking and there was something missing in it. There was something, and Kevin Briggs spoke about it this morning, the hook to hang something on. And I eventually found it because John Kerwin, former All Black, I don't know how John Kerwin goes down in Australia, but he certainly is a legend in New Zealand. But John Kerwin does fabulous work and fantastic work in the whole area of mental health. And promoting mental health. And he has a video called All Blacks Don't Cry. You can get it on YouTube. If anybody hasn't seen it, by all means go on and have a look at it, because it is a powerful video. And when using the video in the training, it immediately grabs the attention of the sports coaches, because they get the relevance of it to what they're about, is about coaching and about the development of their players, and now paying attention to the mental health area. When we do the training, we don't do it in hotel environments and conference environments. We go to the sports venues. We go into the sports dressing rooms. We go to the clubs and the places where the sports people are gathered. We turn up in our tracksuits so that it's very relevant. We train those. And we also now are beginning to train the more senior players in groups, because in sport, the senior players are probably in their late 20s, early 30s. But you've got 17 and 18-year-olds being introduced into that. I remember being introduced at adult level to hurling at 17 years of age. I was looking up at these guys that were my heroes for 10 years. We're now training the senior players so that they can look after the younger players and see if they're able to adapt, and if they're able to deal with the stresses and the pressures that are there. The training covers a list of things. It's very easy for anybody to go onto the QPR Institute and see what the training covers. It's very much the same thing, only that we are doing it from a sporting context, and we use the sporting language in that all of the time. Here's a testimony from Marcus Horan. Marcus Horan is one of the legends of Irish rugby. He was a British and Irish Lion. He did a QPR training, and his testimony was that the QPR course has provided me with the tools to spot the signs of suicide. It has given me the empathy to speak to someone who is troubled, and the confidence to refer them to the right type of help. Now, if we can have former, British and Irish Lions giving that type of a testimony back, just think of the impact it can have back down at a local level in local sports clubs. One of the other people that I often mention when I'm doing this is that, the impact that sport can have, and being suspended and different things. One of our top players in Ireland was picked to play with the Lions on a tour to Australia a number of years ago, Alan Quinlan. And 2 weeks before he left to go on that tour with the Lions, he played in a rugby match with Munster against Leinster, and he was cited by the match referee for gouging Leo Cullen in the eye. It was kind of an innocuous enough thing, but that's what it ended. He was not allowed to go on the British and Irish Lions tour. He lost what he had always strived in, and he suffered dreadfully from depression as a result of that. Of course, there may have been other extenuating circumstances, but certainly it was a catalyst that drove him into very, very severe depression. And both himself and John Kerwin speak very, very eloquently and very well about the whole area of mental health and depression in sport. I think that brings me to 0000. Thank you very much for listening. It's been a pleasure to be here, and I hope that you were able to take something from that. Thank you.